Welcome to Module 1 lecture. This lecture includes the perioperative care, patient care before, which is considered preoperative, during, intraoperative, and after postoperative surgery is considered the perioperative experience. Patient safety is the number one priority throughout this period, and it requires teamwork and interprofessional collaboration. Research identifies communication, which is the critical component of teamwork and collaboration, as a critical element in maintaining patient safety in the perioperative environment. The perioperative period begins when the patient is scheduled for surgery, and it ends at the time of transfer to the surgical suite. The nurse prepares the patient for surgery and ensures patient safety. When taking a preoperative history, it is important to be as thorough as possible. You want to collect essential data elements, which include age, general status of health, review of systems, their medical history. Their medical history would include their current medical problems, their treatments, any allergies or sensitivities to latex products, any history or type of prosthesis that they may have. It's also important to know their surgical history, any previous surgeries that they've had, how did they tolerate those surgeries, did they have any complications, have they had any prior experience with anesthesia or any trouble after having anesthesia, such as having difficulty being aroused or ongoing nausea and vomiting, and what's their prior experience with post-surgical pain control. Their social history is important as well. Do they use any tobacco, alcohol, illicit substances, marijuana, which may be legalized in certain states, any current drugs that they take? This includes prescribed and over-the-counter medications, any use of complementary alternative therapies or practices, such as vitamins, minerals, herbs, herbal preparations, any folk remedies or acupuncture. Caregiver history is important to review the relevant information about family members that may have had similar surgeries in the past and their outcomes. Is there any history of malignant hypothermia, any history of cancer or bleeding disorders, or any reactions or complications associated with the anesthesia? Psychosocial status is important to know about the knowledge and understanding of events during the perioperative period and their comfort level with understanding the type of surgery planned and the anticipated outcomes. What's their support system like? Are they going to have someone at home to help them if they need someone to assist? Culture and spiritual needs should be addressed as well, especially their desire for or against any autologous or directed blood or blood product donations, or if they have any kind of post-surgical culture needs or spiritual support. So when we want to assess, we want to focus on patient-centered care. So malignant hypothermia is actually important to ask the patient about any previous experience with anesthesia in their family history, because malignant hypothermia is a genetic predisposition, and they're at risk when exposed to halothane, enflurane, isoflurane, desflurane, sevoflurane, and succinylcholine. Some tests could be performed if they have a history or family history of malignant hypothermia to check to see if they're susceptible to that. A muscle biopsy could be tested with the caffeine halothane contractor test, and then genetic tests on blood to assess presences of RYR1 gene, which this testing may not be covered by their insurance. Patients with a history of malignant hypothermia in their family, you want to monitor those patients for the cluster of elevated end-tidal carbon dioxide levels, decreased O2 sats, and tachycardia. If any of these changes begin, we want to immediately alert the surgeon and the anesthesia provider. And we'll go into more detail in a few slides about malignant hypothermia and its treatment. So with the perioperative patient, we want to report any pertinent cardiovascular and respiratory findings. This includes like any chest pain, irregular heart rate, hypo or hypertension, heart rate less than 60 or greater than 100, any shortness of breath, dyspnea, tachypnea, any pulse ox readings of less than 94%. Do they have a pacemaker or an implantable device, such as a cardioverter, or defibrillator? Report any signs and symptoms of infection. This would include fever, purulent sputum, increased white blood cell count, dysuria or cloudy, foul-smelling urine, any red, swollen, draining IV or wound site. And that might be why they're having surgery, is to clean out the wound, but we still would need to report any other findings that might suspect infection. We want to report any laboratory data that can contraindicate surgery. Are they hypo or hyperkalemic? Do they have a positive pregnancy test? Or did the patient report of an actual or possible pregnancy? Increased prothrombin times, international normalized ratio, the INR, or activated partial thromboplastin time would need to be reported. Don't forget to include any decreases in hemoglobin or hematocrit and platelet counts. Report any other clinical conditions that may need further evaluation before proceeding with the surgical plans. If they have a rash, if they're vomiting, any change in mental status, if they just got a dose of anticoagulant drug. We want to use a standardized form to ensure that the following items are available before surgery starts. So we use the standardized forms to check to make sure we have a history and physical that's signed, dated, and witnessed, a procedure consent form, nursing assessment, pre-anesthesia assessment, labeled diagnostic and radiology test results. Other common test results would maybe include a chest x-ray or an electrocardiogram, ECG, and then any other test specific to the scan, MRI scans, abdominal films, orthopedic films should also be noted. And then check for any banked blood products. Do they have any blood products on hold? Do they have any implants or devices? Or will they need any special equipment for the procedure? What's the patient's preferences about blood product transfusion? This should also be addressed. So recognizing cues, critical rescue, we want to recognize a potassium imbalance when we're reviewing laboratory reports. If hypo or hyperkalemia is present, we want to respond this to the physician, surgeon, anesthesia provider, and the perioperative team so that the imbalance can be corrected before surgery. Analysis. Let's analyze cues and prioritize hypotheses. The priority collaborative problems for preoperative patients are the need for help teaching due to unfamiliarity with surgical procedures and preparation. So they're not familiar with these surgical procedures and preps. Some people have never even been in a hospital before they're having to have some type of surgery done. So that leads to anxiety, fear of the new or the unknown. It's a new experience, fear of pain and or the surgical outcomes. So we need to be sure we're educating on these points to these clients. So you want to explore the patient's level of knowledge and understanding of the planned surgery by having the patient explain in his or her own words the purpose and expected results. This lets you know if they really understood what was told to them. Joint commission requires the correct site is selected and the wrong site is avoided. So the correct site should be marked by a licensed independent practitioner whenever possible and involve the patient. We want to ensure proper patient identification. This includes placement of the identification bands, We want to use at least 2 appropriate identifiers. So name, date of birth are examples of 2 appropriate identifiers we would use. We want to ensure an informed consent is obtained from the patient or their legal designee by the surgeon before we give them any type of sedation or sedative and before surgery is performed. When we're getting informed consent, this consent implies that the patient has sufficient information to understand the nature of and reason for the surgery. Why are they getting the surgery? Who will perform the surgery? Are there going to be other surgeons in the room? Will they be present during the procedure? Who else will be in the room helping the surgeon? All available options and the risk associated with each option. Is there something they could have done before? Or maybe what are the other options when they get in there to do surgery? Are they just doing exploratory surgery, but then possible other things depending on the findings? The risk associated with a surgical procedure and its potential outcome should be discussed with the patient, and the risk associated with the use of anesthesia, and risk, benefits, and alternatives to the use of blood products. This is an example of a informed consent form. So you would have the patient read over it. It would specify specifically what kind of procedure is being done, the correct side if it was lateral, either right or left. If there was more than one option, you would have the patient sign it. The physician should sign it, and then they would have a witness sign this as well. If you needed to, you could get telephone consent from the patient's designee. If you did get a telephone consent, you would need 2 witnesses for that as well. So planning, implementation in the preoperative period. Before surgery, we want to be certain to provide patients with information about that informed consent. It says surgeon will obtain. Usually the surgeon discusses the surgery with the patients and then leaves it up to the nursing staff to get it actually signed. But some will do it in their offices if it's a planned surgery. Some will have their mid-level get the consent signed form. You also want to discuss any dietary restrictions with the patient. Let them know that they're going to have nothing to eat or drink before the surgery, or if they have any other restrictions leading up to the surgery. Any specific preparation for the surgery, any kind of bowel or skin preps that they may need. Exercises that are required after surgery to help prevent blood clots, pneumonia, any of the post-op complications. And then plans for their pain management following procedure. Not only just medications, but maybe some other techniques to help with pain control. We want to help promote patients' direct participation in their own care. This will help them achieve better outcomes. If they participate and plan out what their care is going to be like, and we follow that plan, they're more likely to follow that plan post-op and then have better outcomes. Just keep in mind, informed consent must be obtained from the patient or legal guardian if the patient's unable to do so. The surgeon, like I said, would explain the procedure, risk, and benefits to the patient. We will serve as a witness to the patient's signature, and we can also provide advocacy to assure that the surgeon provides further procedural clarity if the patient or legal guardian seems unclear about the contents of the document. So if they weren't sure what they were signing or why they were signing it, why exactly, any questions at all that they had about this, the patient has the right to hear from the surgeon, so we could reach out to them and say, hey, this patient doesn't want to sign their consent just yet, they still have some questions, and then they can have the surgeon come back and discuss it in further detail with the patient. So generate solutions and take action. If you believe that the patient has not been adequately informed, any questions about the procedure, or if there's a discrepancy related to the surgical site, it's your professional and ethical duty to contact the surgeon and request that the surgeon and see the patient for further clarification. And then don't forget to document this action in the EHR. Site marking is another important key step before surgery. We want to avoid any wrong site, wrong surgeries. So the Joint Commission's National Patient Safety Goals ensure that the correct site is selected and the wrong site of surgery is avoided. We will mark it, the surgeon, licensed independent practitioner or surgeon will mark it prior to the first incision and whenever possible by the patient as well. So preoperative care of the patient, you want to determine the existence and nature of the patient's advance directives. Do they have a living will? Do they have an advance directive? And do we have copies of those if they do? We want to implement and evaluate adherence to oral or dietary restrictions. Have they had nothing to eat or drink? Usually it's recommended nothing solid or for at least 6 hours or more before surgery. And if they're on a clear liquid diet, at least 2 hours. Actually, if they eat any kind of fried fatty food, they need to be NPO for at least 8 hours. So that patient that just ate a single piece of bacon for breakfast because they didn't realize they were having surgery that day will have to wait a full 8 hours before surgery can safely be performed. Or it will be postponed for the next day. If they do eat something, that just increases their risk for aspiration during or after surgery. You also want to ensure if they were supposed to have any kind of intestinal preparation that was completed. Sometimes they'll have enemas until clear, or mild and potent laxatives may be prescribed to empty the large intestine, just to reduce the potential for any contamination in the surgical field. The preoperative EHR review and pre-op patient prep can be found on page 175. We want to also correctly administer any prescribed preoperative drugs. This includes any cardiovascular drugs or antibiotics. A lot of times patients will have an order for an antibiotic at least 1 hour prior to incision, which a lot of times is given in the pre-op area. Many oral drugs are held the morning before surgery, or they're given via IV preoperatively. A lot of your ARBs and ACE inhibitors, insulins, and oral glucose medications are examples of medications that may be held the morning before surgery because they have the potential of causing hypotension during the surgery. Or drop in blood sugar in the middle of surgery. So to avoid those complications, they will usually hold those medications. Other blood pressure medicines, beta blockers, calcium channel blockers, those are usually okay to give with a sip of water. Any medications that they may take for respiratory diseases, seizures, and hypertension are usually also allowed before surgery with that sip of water. We want to keep side rails up, the bed in low position, and the call light or call system within easy reach of the patient, especially after administering any pre-operative sedatives. If the patient requires any skin prep, that would need to be done. The diagram on the right shows you different areas about prepping the skin for potential surgery. You want to confirm and assist the patient in the use of any antiseptic solution while showering and removal of any oil and skin debris. You want to help instruct them how to follow those directions of using that soap appropriately. A lot of times it's not rinse off, and they'll usually do a shower the night before, the morning of also, so both times. So just making sure the patient understands when they should take or use the skin antiseptic solution. This does reduce the number of organisms on the skin to decrease the risk for a site infection. And then if there needs to be any hair removal At the surgical site, it should be done with clippers and not any razors. We also want to teach the patient about the potential use of any tubes, drains, and vascular accesses. Reassure the patient most of these are temporary and that efforts will be made to reduce discomfort. So Foley catheters, NG tubes, drains, such as Penrose, Jackson Pratt, and Hemovac, and then any vascular accesses needed for IV infusions or medications. Generate solutions, teach the patient that deep vein thrombosis is swelling in one leg, the presence of calf pain that worsens with ambulation or worsening shortness of breath. So they'll be using anti-embolytic stockings like TED hose, elastic wraps, or pneumatic compression devices, or IPCs, intermittent pneumatic compression devices, to prevent superficial venous stasis and VTE. Teach them the leg exercises and early ambulation. Mobility is medicine, to prevent those complications. Review their plans for pain management postoperatively. If they're receiving any type of sedation or general anesthesia, stress the importance of having another adult drive the patient home after their procedure. They shouldn't be driving themselves. Ensure appropriate clothing removal and storage of valuables. If they have any valuables, we want to make sure that they're being sent home with family or that we're marking them so that the patient gets all their belongings after surgery. Have the patient remove any dentures, dental prosthesis, jewelry, eyeglasses, contact lenses, hearing aids, wigs, any other prosthesis, any extra clothing. You wouldn't want any clothing that would contain metal, because then it becomes a burn risk or burn hazard in surgery. The next 3 slides talk about postoperative leg exercises, and this can be found in your book on page 172, showing the patient how to do these leg exercises while they're in the bed recovering. So sitting up, just bending and raising their leg, alternating feet and legs a few times. And then doing the stretches with their right leg, pointing their toes toward the bottom of the bed and then lifting it back up like they're stepping on a gas pedal, and then circling their ankles or other techniques. All these can be done postoperatively while the patient's laying in the bed, and it helps also prevent them from getting any complications with DVTs or VTEs. And this is another exercise, just bending the right legs and pushing the ball of their feet into the bed till they feel that calf muscle and thigh muscle contracting, and they want to perform that several. Patients should be given a checklist that teaches them how to prepare for surgery. So what to do 72 hours before surgery, day before surgery, or the day of surgery. And it guides them through the steps given to the patient. And then we have a checklist that we're going to follow. Did we identify the correct patient? Or is the consent on the chart? Is their site been marked, or was it necessary to mark the site? Do they have an H&P on their chart? Did anesthesia do a pre-anesthesia assessment? Did we do a nursing assessment? Have they had tests, and are those available? Test results and lab results available? Or are they going to be getting any blood products? Do they have any in the blood bank? Are they going to need any kind of special devices? All that should be done pre-operatively. When they sign in, they're going to continue. Before they give anesthesia, they're going to confirm that yes, this is the patient, yes, the site is marked, yes, allergies or no allergies, what's their oxygen level, how difficult would be for intubation, or how high at risk are they if they needed to be intubated. And then a timeout is performed prior to skin incision, where every member of the team freezes and follows a script to make sure that you do have the right patient, you are performing the correct surgery and the correct site. And then before the patient leaves the actual surgery area, they will do a sharps count, they'll do a sponge count, instrument counts. Any specimens would be labeled, is all the equipment, problems, anything like that addressed. And they also do a little timeout or sign out checklist for patients. We want to evaluate how was that care of that preoperative patient based on the identified patient problems, the expected outcomes. That include, does the patient understand the informed consent and the preoperative procedures? Do they understand the exercises, techniques, and prevention of complications? And do they verbally have reduced anxiety since we gave them that knowledge? Your Med-Surg ATI book has a section on anesthesia and moderate sedation. This can be found on page 743 through 747. This talks about the different types of anesthesia that can be given. There's general anesthesia, which is that deep depression of the central nervous activity, depression of consciousness, loss of responsiveness to stimulation, muscle relaxation, and memory loss of the surgery. Regional anesthesia is a local conduction or field block, like an epidural or spinal and nerve block, and it causes reduction in sensation in selected parts of the body. Local anesthesia involves an injection or topical application of an anesthetic agent to a targeted area. And then there's moderate sedation. It involves, is combined with local anesthesia. It's generally used during scheduled therapeutic procedures to control the client's pain and anxiety while providing effective sedation. So your specialty areas like endoscopy and special procedures may use moderate sedation. If the patient's going for a colonoscopy, for example, they would be getting moderate sedation. So just be familiar with the different types of anesthesia, what medications that they will use, and any complications that can arise from the use of moderate of anesthetics. This slide gives you examples of the timeout process in the OR. There is an example of the right way to do it and then the wrong way to do it. So I suggest that you, or encourage you, to watch both versions and to determine the importance of the timeout. Joint Commission it is part of their national patient safety goal to make sure that we do have the right patient, the right site, and the right surgery being done, and other things as well, but those are the three main things: the right site, right patient, and moving on to the postoperative period. This starts with the completion of the surgery procedure and the transfer of the patient to a specialized area for monitoring, such as the PACU or ICU. It can extend beyond discharge from the hospital until any activity restrictions have been lifted. During phase 1 of the postoperative care, we're going to closely monitor the patient's airway, vital signs, and any indicators of recovery at least every 5 to 15 minutes. This stage or phase usually lasts 1 to 2 hours. In phase 2, we're going to focus on preparing the patient for care in another setting, such as an acute care unit, ICU, skilled nursing facility, or even for discharge home for those outpatient procedures or surgeries. Phase 3 occurs in the extended care environment, which could be the hospital or the residence, with assistance or self-management. A handoff report that meets the Joint Commission's National Patient Safety Goals requires effective communication between the anesthesia provider, circulating nurse, and PACU or ICU nurse. This includes the type and extent of the surgical procedure, what type of anesthesia was used, and the length that the patient was under anesthesia, Any allergies the patient has, especially to latex or drugs? What's the patient's primary language? Do they have any sensory impairments or any communication difficulties? Did they have any special requests that were verbalized before surgery, including communications with their caregiver? What was their respiratory function or dysfunction preoperatively and intraoperatively? Any health problems or pathophysiologic conditions? Any relevant events or complications that occurred during anesthesia or surgery, such as a traumatic intubation? If intraoperative complications occurred, how were they managed? And what were the patient's responses? Checking lab values. Did they have any excessive blood loss? Did they sustain any injuries? What was their intake and output, including what's the current IV fluids being administered and their estimated blood loss? What type and amount of IV fluids or blood products was administered during surgery? Any pain medications that were given? When was the last dose given? When is the next dose of antibiotics, cardiac drugs, and other medications due? Where are their incisions? Do they have any dressings, any catheters, tubes, drains, packing? And then do they have any type of prosthetic device, existing or applied? As we discuss cues to monitor for within each organ system, you will analyze the cues and prioritize the hypotheses that aligns with the recognized cues. Number 1, potential for decreased gas exchange because of anesthesia, pain, opioid analgesics, and immobility. 2, potential for infection and delayed healing due to wound location, decreased mobility, drains and drainage, and tubes. 3, acute pain due to the surgical incision and procedure and surgical positioning. 4, potential for decreased peristalsis due to surgical manipulation, opioid use, and fluid and electrolyte imbalances. And then 5, potential for postoperative bleeding or hemorrhage due to surgical procedures. So assessing the patient. The initial assessment of the patient immediately after surgery includes the respiratory status. Think A, B, C, D, airway, breathing, circulation. Disability, you'll get to that. Respiratory status, this includes their peripheral oxygenation or SpO2. What's their level of consciousness? Their temperature, pulse, blood pressures. A set of vital signs will be obtained initially after surgery and throughout the recovery period. Respiratory assessment, as I said, is the most critical assessment to perform after surgery for any patient who's undergone any general anesthesia or moderate sedation, or if they received any type of sedative or opioid drugs. You want to evaluate the airway patency and adequacy of gas exchange by checking their O2 stat, their end-tidal CO2 carbon dioxide levels, any respiratory rate, pattern, effort, are they struggling to breathe? Ensure the security and placement of any artificial airway. Do they have an endotracheal tube, a nasal trumpet, or an oral airway? Are those positioned correctly? And mark if it is an endotracheal tube, paying attention to where that tube is marked. It may come out, it's not usually pushed back further in, but it may get pulled back out. Maintain the type of oxygen delivery device and the concentration of oxygen delivered. Auscultate lung fields for breath sounds. Examine the symmetry of those breath sounds and chest movement. Is there any presence of snoring or stridor? This could represent an obstruction if there's any snoring or stridor. To improve gas exchange in the postoperative patient, we want to first monitor. We want to look for any snoring or stridor, which could indicate obstruction. Obstruction can be caused by swelling or spasm of the larynx or trachea, any mucus in the airway, or relaxation of the tongue into the nasopharynx. We can also check by positioning. Side lying or elevated backrest position is best to help prevent aspiration. Applying any oxygen as prescribed. It could be by face tent, nasal cannula, or mask. And then encourage breathing exercises and assist the patient to breathe deeply, usually splinting the incision site and using the incentive spirometer. Suction the mouth, nose, throat as needed to keep the airway clear of any mucus or vomitus. Assist the patient to reposition. Movement is best. Help them reposition themselves. They need to be moving or turning at least every 2 hours. And then encourage ambulation as soon as possible. It is best to get them up and moving as soon as they can tolerate it and are alert enough. That way they prevent any post-op complications that may occur. In the case of an emergency, you would want to keep a manual resuscitation bag and emergency equipment nearby in case the patient needs to be intubated, or even have a tracheostomy kit nearby. Implement a head tilt chin lift maneuver to pull the tongue forward and open the airway if it's obstructed. You may have to insert an oral airway or a nasal airway to pull the tongue forward and hold it down. If they're having decreased oxygen sat or change in the level of consciousness or cyanosis occurs, call the rapid response team and plan to assist with insertion of the oral airway if needed. An initial assessment and continuing monitoring of a patient's respiratory status should be completed for anyone who's undergone general anesthesia or moderate sedation, or if they received any type of sedative or opioid drugs. Patients who's undergone moderate sedation with a benzodiazepine, such as midazolam or lorazepam, may be overly sedated or have respiratory depression. And the potential for decreased gas exchange because of benzodiazepine overdose. Emergency care of the patient experiencing a benzodiazepine overdose. These planning and implementation solutions can be found on page 185 in box 911 in your book. You want to secure the airway and IV access before you start any type of benzodiazepine antagonist therapy. Administer oxygen and prepare to administer flumazenil. Flumazenil is the antagonist for the benzodiazepine. That drug can be given every 2 to 3 minutes as ordered, depending on the patient's response. Suction will need to be set up, continuously monitoring vital signs and their level of consciousness. You're looking for reversal of that overdose. And don't leave the patient until they're fully responsive. Vital signs are going to be administered or checked every 10 to 15 minutes for the first 2 hours. An additional flumazenil therapy may be ordered. So flumazenil has a shorter half-life and it doesn't last as long as the benzodiazepine. So they may need another dose. Observe for any tremors or convulsions from the patient. Flumazenil can lower the seizure threshold in those with seizure disorders. Assess the IV every shift because it can cause thrombophlebitis at the injection site. Observe for those side effects of flumazenil. These include skin rash, hot flashes, dizziness, headache, sweating, dry mouth, and blurred vision. The incidence of these effects, of course, increases with the higher total doses of flumazenil. So the more flumazenil you give, the higher their risk for developing these side effects. Along with assessing their respiratory status, we do need to also monitor their neurologic status. We'll go into more detail in Module 4, but things to look for are their level of consciousness or awareness, the trending, any presence of lethargy, restlessness, or irritability. Can they respond to stimuli? Is it verbal stimuli, such as just calling the patient, tactile stimuli, touching the patient, and giving simple commands, such as open your eyes and take a deep breath? Or do they respond to painful stimuli? What's their degree of orientation? Are they confused? Do they know who they are? Person, place, time? What's your name? Where are you? What day is it? And then compare the patient's baseline preoperative neurologic status with those postoperative findings. We want to assess the surgical area. So looking at those incisions, looking for any bleeding and drainage or any signs of infection. This does include looking at any dressings or drains. We want to document the color, amount, consistency, and odor of any drainage. Examine for leakage around or under the patient. Do we not see it? Is it coming out and pulling underneath them? Determine the patency of drains. Are they pulling the fluid off as they should or designed to? What's the condition of the sutures and staples? Are they clean, dry, intact? Is there any open areas? Note those open areas. And perform any neurovascular checks to identify restriction of circulation or sensation. These are pictures of the different types of drains. These are also located in your book on page 187. The top one is an example of a Penrose drain, which would be placed in the incision. It's a gravity drain, and it just gravity drains the fluid out from the abdominal cavity or wherever the drain is placed in the incision. The other gravity drain is in picture B. That is called a T-tube drain. Picture C is your closed wound drainage systems. That's the Jackson Pratt or JP drain, and then the Hemovac drain is picture D. So we want to prevent wound infection and delayed healing. So we're going to reinforce the dressings, change the dressing if we have orders, assess the wound for healing and for any signs of infection. Care for those drains, including emptying drainage containers and reservoirs, measuring the drainage, documenting drainage features. We don't want those to get backed up. They wouldn't not pulling off the adequate drainage can cause the site to become infected. The surgeon does usually perform the first dressing change to assess the wound, to remove any packing or pull out or advance any drains, and then they'll place orders for dressing changes. If we have an unchanged wet or damp dressing, is a source of infection, so we encourage also education point for the patient not to get their dressing wet or damp. Skin sutures or staples are usually removed 5 to 10 days after surgery, and we generally administer antibiotics no longer than 24 hours after surgery unless the patient already has a documented infection. As a note, the dressing that's pictured there are called Montgomery strips, and those are good to use if a patient is getting multiple or frequent dressing changes, that you can just change the dressing that is close to the skin without having to keep removing and adhering tape. They're called Montgomery strips. Complications that can occur with the incision is dehiscence. This is a wound opening or rupture that occurs along the surgical incision. And then an evisceration is a wound opening with protrusion of the internal organs, and this is considered a surgical emergency. Dehiscence or evisceration can be caused by forceful coughing, vomiting, or straining, and when not splinting that surgical site during movement. The patient may state, "Something popped," or I feel like I just split open." We want to monitor our surgical incisions at least every 8 hours to recognize any impending evisceration. When we do recognize a surgical wound evisceration, we need to notify the surgeon or rapid response team immediately. There are also other steps we can do for emergency care of the patient with that surgical wound evisceration. These are listed on page 187 in box 912 for you. So the first step, call another nurse, call for help so they can bring you supplies, they can notify the physician, surgeon, or the rapid response team. We want to stay with the patient for reassurance and support to ease that patient's anxiety. We're going to encourage them to stay in the bed. We are going to lay them in a supine position, bend the hips and knees, and raise the head of the bed 15 to 20 degrees. And then when your supplies come, we are going to place a warm dressing that's moistened with a saline solution over the exposed viscera. We want to use a sterile technique with this because these are organs or body parts coming out, so we want to keep those sterile. So we do want to cover them and keep them moist as well. So we may have to keep reapplying saline solution to keep that dressing moistened. Do not attempt to reinsert the protruding organ or viscera. That is up to the surgeon. They can do that. During surgery, we do not want to put their intestines back in, or whatever the organ or viscera is. Assessed for symptoms of shock. We're going to be checking vital signs every 5 to 10 minutes until the surgeon or the rapid response team arrives. Keep those dressings, as I said, continuously moist. Don't let the dressing become dry. When the surgeon or RT arrives, report those findings and interventions that we've done, and then don't forget to document. If necessary, prepare the patient for emergency surgery, start IV infusion as ordered, and don't allow the patient to have anything by mouth because they are going back down to have this repaired. I say down, they are going back to surgery to have this repaired. So recognizing cues, assess your vital signs on admission, and then follow an agency protocol for how frequently you assess vital signs. We want to assess their cardiovascular status. Look for any changes in heart rate, blood pressure, respiratory rate, or peripheral oxygenation. Any changes that are concerning need to be communicated to the provider or rapid response team. High or low values in vital signs can be early indicators of adverse reaction to any operative drugs, blood or volume loss, or post-operative complications, including myocardial infarction or stroke. When prioritizing, your cardiovascular status belongs to which part of the ABC framework? Correct, circulation. You want to evaluate the heart rate, quality, and rhythm. Carefully monitor blood pressure values, electrocardiography for dysrhythmias, monitor those, EKGs. Compare distal pulses, color, temperature, and capillary refill on their extremities. Examine their feet and legs for any manifestations of DVTs, redness, pain, warmth, or swelling in the legs. And then maintain prescribed compression devices or anti-embolytic stockings in the preoperative or operative suite that were applied in the preoperative or operative suite. We want to recognize any cues of pain. PQRST is a pain assessment, and it's a mnemonic used to evaluate the patient's pain by asking questions about the following aspects. Provocation or palliation. What causes or increases the pain? What makes it better? What makes it worse? What's the quality of the pain? What type of pain is it? Would you describe it as sharp, dull, burning, aching? Region or radiation. Where on the body does the pain occur? Where does that pain originate from? Does it radiate? Does it move anywhere? Severity. How severe is the pain on a scale of 0 to 10 or any other appropriate pain assessment tool, like the FACES scale. And then time. When did the pain start? How long does it last? Is it constant or intermittent? General solutions about managing pain. Administer opioids as prescribed. We want to monitor patients with their first dose to see how they react to those. Assess the type, location, intensity of the pain before we give medications, and don't forget to follow up after giving those pain medications to see if they were effective. Monitor the patient's vital signs for any hypotension or hypoventilation after giving an opioid drug. Use around-the-clock scheduling or use patient-controlled analgesia systems or PCA systems for consistent blood levels and more effective surgical pain management. Offer prescribed pain medication about 30 to 45 minutes before the patient gets out of bed so that they'll get up and move around. They won't be not wanting to move because of the pain. Use non-opioid drugs to augment pain management. Typically, NSAIDs or acetaminophen are used. And use adjuvant therapy like distraction, positioning, relaxation, anxiety-reducing interventions to help manage the pain. Whatever works for the patient, find other things that may help with the pain. Also, we may use things like heat or ice to assist as well. This chart shows you common examples of drug therapy management of postoperative pain. You have your opioids, which include your morphine sulfate and hydromorphone, codeine, oxycodone, oxycodone with aspirin or oxycodone with acetaminophen, and then your NSAIDs like ketorolac and ibuprofen. Non-pharmacologic interventions to reduce postoperative pain and promote comfort. Just finding general position of comfort for the patient, sometimes just repositioning, placing pillows to support, using ice to reduce and prevent swelling as indicated, cushion and elevate painful areas. You want to avoid placing tension or pressure on these areas, so you don't want to place pillows under the knees, and do not raise the knee gauge. You want to control or remove any noxious stimuli. Provide adequate rest to increase pain tolerance. Encourage the patient's participation in diversional activities. Teach relaxation techniques like music, deep breathing exercises, and also maybe provide opportunities for meditation as well. In emergency care of the patient experiencing an opioid overdose, we are going to give naloxone. It can be administered IV, IM, subcutaneously, or nasally. The IV route does have the most rapid onset and is recommended in emergency situations. If we don't give the initial dose as IV for any type of reason, we want to remain prepared at all times to administer it IV if ordered. We want to maintain an open airway. If the desired degree of improvement in respiratory functions is not obtained, naloxone dosing may be repeated 2 to 3 minute intervals if needed, depending on the patient's response. Once again, it does have a shorter half-life, so they may require another dose. We want to give them oxygen if there's any hypoxia present or if their respirations are below 10 breaths per minute. Have suction setup available because naloxone can trigger vomiting, and then a drowsy patient is at risk for aspiration if they're vomiting. We want to continuously monitor vital signs and level of consciousness for any opioid reversal every 10 to 15 minutes for the first hour. It's eliminated from the body more quickly than is the opioid. Like I said, it has a shorter half-life, and it may induce side effects. These side effects include blood pressure changes, tachycardia, and dysrhythmias. So we don't want to leave the patient until they are fully responsive. And then also assess the patient for pain, because we reverse the opioid, the pain medicine, which also reverses the analgesic effects. So we may need to try another type of pain management. The healthcare provider will determine the need for any additional antagonist therapy 1 hour after the patient initially becomes fully responsive. So next we're going to assess their GI status. We want to listen for bowel sounds in all 4 abdominal quadrants and at the umbilicus. Assess for any nausea and vomiting. Postoperative nausea and vomiting are common with general anesthesia. Administer any prescribed antiemetic drug. Look for any symptoms of a paralytic ileus, which includes few or absent bowel sounds, a distended abdomen, abdominal discomfort, vomiting, and no passage of flatus or stool. Assess and record the color, consistency, and amount of any NG tube drainage, and then check NG tube placement. It should be marked and noted and documented how far the NG tube is advanced. So to promote peristalsis, we're going to monitor bowel sounds, rectal output, and abdominal status, so looking for any distension. with our vital signs. We're going to auscultate for bowel sounds in all 4 abdominal quadrants. We're going to listen for at least up to 1 minute in each quadrant. Gently palpate the abdomen. If they've had abdominal surgery, they're going to be tender or sore, but so gently palpate the abdomen to determine any degree of softness or whether there's any rigidity present. We want to ensure adequate hydration, so when they're allowed to drink something, we want to encourage oral fluids. If they're getting IV fluids, so if they're not able to drink anything, making sure they are on a type of intravenous fluid. And evaluate the intake and output to achieve hydration or fluids balance goals. Promote early and progressive out-of-bed mobility. Get the bowels moving by getting them up and walking and passing gas. And then provide drug therapy to maintain or restore any intestinal peristalsis. Drug therapy could include Alvimopam, or Antereg is the brand name. It's been approved to accelerate the time to GI recovery following certain GI surgeries. And metoclopramide, or Reglan, promotes peristalsis by directly stimulating GI motility. So assess any fluid, electrolyte, and acid-base imbalances. You'll get more in Module 3. So just some highlights: measure your intake and output. Intake and output includes IV fluids, any emesis, urine, wound drainage, any NG tube drainage, drains, drainage as well. Check their hydration status. Look for the color and moisture of mucous membranes. Their turgor, texture, is there any tinting of the skin that might indicate dehydration? The amount of drainage on their dressings, or the presence of axillary sweat. We want to assess their kidney and urinary status. More of this will come in Module 6. So we're going to measure their intake and output, and then assess for urinary retention by inspection, palpation, percussion of the lower abdomen to assess for any bladder distension, or we can use a bladder scanner to determine how much urine is in the bladder, and perform any prescribed intermittent catheterizations as needed, and assess the urine for any color, clarity, and amount. Amount, especially after surgery, especially abdominal surgery, you want at least 20 mLs per hour. So 240 mLs or cc's in an 8-hour period is recommended. Post-operatively, we're going to monitor any motor and sensory function. More will come in Module 8. So we're going to ask the patient to move each extremity, assess their strength of those limbs, comparing the results on both sides. Are they equal? And then gradually elevate the patient's head and monitor for any hypotension. We wouldn't want any orthostatic hypotension. We want to create a teaching plan for the patient post-operatively. That includes pain management, drug therapy, reconciliation of post-operative drugs, safety, whom to contact in case of complications, how to progressively increase activity, which assistive devices are needed, are they weak and they now require a walker, prevention of infection with assessment and care of the surgical wound, teach them how to prevent infection, how to care for any wounds or incisions, management of any drains or catheters that they may end up going home with, nutrition therapy, encouraging protein for wound healing, incision healing, and then follow up with the surgeon. Follow-up is important. If the patient's discharged directly to home, we want to assess that information about the home environment for safety. Can they make it up the stairs? Do they have a ramp if needed? Do they have equipment that they need, like a bedside commode or a walker? And the availability of caregivers. Do they have someone at home that can help them with their daily their activities of daily living? It's all about safety. Ask yourself, can this patient live alone safely? If not, then we need to find a way or give those patients those tools needed to have a safe environment. Reinforce to the patient and family after surgery the specific interventions to prevent complications, such as hand hygiene. Um, Collaborate with a social worker or discharge planner to identify those needs related to care after surgery. May include meal preparations, dressing changes, drain management, drug administration, physical therapy, occupational therapy, any personal hygiene assistance needed. And the patient with any visible scars after surgery may need more emotional support from and acceptance by his or her family. This can also include presence of like a new stoma for like a colostomy or urostomy, whatever the case may be. If dressing changes and drain or catheter care are needed, instruct the patient and family members on the importance of proper hand washing to prevent that infection. Explain and demonstrate wound care to the patient and family, and then when able to, let them perform a return demonstration so that you know they fully understand how to take care of this drain or this wound or dressing. Perform a drug reconciliation with the patient before discharge. Ensure that they know what drugs that they can take while they're at home, what medications that they're going to be going home on. And ensure that drugs for other health problems are resumed as needed. So they take blood pressure medicine at home, they need to continue taking their blood pressure medicine as well. A diet high in protein, calories, and vitamin C promotes wound healing. Vitamin supplementation may be temporarily added to home drugs, or encourage diet meals or foods high in those protein, calories, and vitamin C. Teach the patient to increase their activity level slowly. They need to rest often. Avoid the straining the wound or the surrounding area. Healing requires both time and avoidance of stress. Now, a nurse is planning care for a client scheduled for a surgical procedure. Complete a disease process map for the potential complications: pneumonia, DVT, paralytic ileus, wound evisceration, hypovolemia shock, respiratory depression due to opioid overdose. And that concludes this lecture. Thank you.